All right. So this morning we're going to do chapter 13, and then this afternoon Matt Klein's coming in to do, I think it's 14, the hemodynamic monitoring stuff. There's a lot of information to cover in both sections. These are probably one of the top 2 or 3 most important aspects of critical care paramedic class. So I've made you some handouts for different stuff that we're going to go through. So let's get going. So, because we're transporting people that are sick, they're prone to what? All kinds of heart problems, right? Dysrhythmias, hemodynamic issues, right? What else? Maybe pacemakers, internal defibrillators, external defibrillators, right? How many kinds of pacemakers are there? There's a lot of implanted pacemakers. What kind would we not be transporting people with? Maybe external pacemakers, maybe transvenous pacemakers, right? Things that we need to know about because dysrhythmias, all these different mechanical devices potentially alter our care, right? And for sure make our pucker factor go up when we're transporting these people, right? So what is cardiac monitoring? What's it tell us?
The electrical activity of the heart.
Electrical activity of the heart, okay. And when we say monitoring, we typically talk about a 4-lead, right? 4 leads tell us 3 things. Rate, rhythm, do you need a shock or not? It's the only things they can tell you. Everything else that we need to know is derived from the 12-lead EKG, right? And we'll talk about it more as we go. Because the electrophysiology changing might have implications for patient care, it's pretty important that we not only be able to recognize regular lead 2 dysrhythmias, but also the stuff that we're going to look at on a 12-lead. So, what other kind of things can change the electrophysiology?
Electrolyte imbalances.
Electrolyte imbalances, medications, right? That's a big one. Medications, when you're talking about beta blockers, calcium channel blockers, double blockers like amiodarone, it's sodium and potassium channel blockers, all these different things. Digitalis, digoxin. There's a lot of different stuff that can change the way we do stuff. So, all right. So, what's different about cardiac cells, cardiac muscle cells, than any other muscle cells in the body? Automaticity. What's that mean?
The heart cell's ability to transmit non-electrical signals.
Yeah, so they create their own impulses, right? And typically they don't do that unless what? Unless they're ischemic, right? And when they're ischemic, then they start throwing out stupid things like PVCs, runs VTAC, torsades, dumb stuff like that, right? So that's called automaticity. And how does our heart get its blood? How does the heart muscle itself get its blood? What perfuses the heart muscle? Coronary arteries, right? And is the heart muscle, what part of the cardiac cycle is the heart muscle perfused in? Systole or diastole? Diastole, exactly. So basically, the coronary arteries come off of part of the aortic arch, right? Right and left coronary arteries, and then they provide blood flow to the heart muscle itself. So there's a lot of connections between the arterioles of the coronary arteries and the heart muscle themselves. So, first handout I got here. I even made it in color for you. Okay? I'm going to give you a clue. Red means oxygen. Blue means no oxygen. Okay? And you should have another sheet that's got coronary arteries on it. Just a blank sheet. Pretty much it's got, that's this one right here. It says left coronary artery, right coronary artery, and posterior descending artery. So we're going to go through that one first. Okay? So, when we're looking at coronary artery anatomy and blood flow distribution, most people follow a specific pattern. We're going to talk about that, the 90%, 10%. So this should be your pretty much blank sheet. You got right coronary artery, left coronary artery, and it's broken into LAD and circumflex, and then the PDA. Does everybody find it? Looks like this. All right. So let's go down the right coronary artery. So the right coronary artery provides blood flow to the right atrium. The right ventricle. The inferior left ventricle. 60% of the blood flow to the SA node. And 40% of the blood flow to the AV node. Okay. Your left coronary artery, the main part of it's called the left main, or the LCA. And then it splits into the left anterior descending artery and the circumflex artery. So the LAD provides blood flow to the ventricular septum, and what's important about the septum? What important electrical anatomy lives in the septum? Bundles, your bundle branches. Okay? It provides blood flow to the anterior portion of the left ventricle. It provides the other 40% of the AV, or of the SA, and the other 60% of the AV. Your circumflex gets the lateral aspect of the left ventricle. All right. We're going to tie 12 leads to these arteries right now. Okay? 2, 3, and F look at the inferior left ventricle. 2, 3, and F look at the inferior left ventricle. Two, 3, and F look at the inferior left ventricle. So that means that's a right coronary artery problem. Correct? In 33% of inferior MIs, we also have right ventricular involvement. So if I have a right ventricular infarct, which artery is involved? Right coronary, but it's proximal. It's a lot higher up in the artery that's blocked up. Correct? Okay. One AVL, V5 and V6. Look at the lateral part of the left ventricle. So what artery? Circumflex branch of the left coronary. V1 and V2 look at the septum. V3 and V4 look at the anterior left ventricle. Both of those are LAD.
Say that again. 3, 4.
1 and 2 look at septum. 3 and 4 look at anterior left ventricle. Both of those are fed by the LAD. Now down below there, it talks about the PDA, posterior descending artery. That's the coronary artery that perfuses the back of your heart. And this is where the normal distribution patterns exist. So 90% of the population are considered right dominant. 10% of the population are considered left dominant. What that means is, in 90% of the population, the PDA, posterior descending artery, originates on the right coronary artery. The other 10% are left dominant. That means the PDA originates off of the circumflex. So let me recap. 2, 3, and F. Inferior left ventricle, right coronary artery. Right ventricular infarct, proximal right coronary artery. 1, AVL, V5, V6, lateral, left ventricle, circumflex. V1 and 2, septal, V3 and 4, anterior. That's your left anterior descending. So what would happen if I had changes in the 1, 2, 3, and 6? 1 and 2 are septal, 3 is anterior, 6 is lateral. Which artery? What gets V5 and 6?
Circumflex.
So I have the circumflex and the LAD, right? So does it make sense that the blockage is in the left main?
Yeah.
That's called the widowmaker. So left main blockage is going to get you anterior, septal, and lateral, or maybe some combination, or even some inferior involvement. So if you have to put more than 2 names together, so anterior septal, anterior lateral, inferior lateral, if you have to put more than 2 names together, then chances are it's a left main problem. Okay, and those people are the sicker people. Those are the people who are typically in cardiogenic shock, pulmonary edema, super sick people. All right. Are we clear as mud? Everybody with me? So now let's look at our nice red and blue drawing. So, if you start at the top on the left, and we talk about the blue arrow going down in the big hole, what do you suppose that big hole is? What? Superior and inferior vena cava, the top, right? It's the superior vena cava. Big blue blood going into the what? Right atrium. So that is the 5th line down. Then it goes through the tricuspid valve, which is the next line down, into the right ventricle. Then where does it go? Pulmonary valve into the pulmonary arteries, And so as you go up the pulmonary artery and you go left and right with the arrows, then it branches off into two different pulmonary arteries, right? And both of those go to the lungs. Everybody following? Right below that, you have two other arteries or two other vessels that have red arrows. What are those? Pulmonary veins. And that comes from the lungs into the left atrium, through the mitral valve, into the left ventricle, through the aortic valve. And what's the big red circle on the top? The aorta. That's your aortic arch. And what are those things, those three red arrows at the top, you think? Carotids and subclavians. And then what's the big red arrow at the bottom? Descending aorta. So let's recap this. Superior vena cava to right atrium. Tricuspid valve, right ventricle. Pulmonic valve, pulmonary artery, lungs, pulmonary veins, left atrium, mitral valve, left ventricle, aortic valve, aorta, body. Everybody good with that? We will carry on. All right. Heart sounds. Where do we get heart sounds? What causes heart sounds? Valves doing what? Mostly closing, slamming shut. So how many heart sounds do we have normally? Two. One's called S1, one's called S2. We typically hear it lub-dub, lub-dub, lub-dub. So S1 is your atrioventricle valves slamming shut. So that's your tricuspid valve and your mitral valve. Dub, or S2, is your pulmonic valve and your aortic valve slamming shut. Lub-dub, lub-dub, lub-dub. How many of you normally listen to to heart sound? It's a bad habit, right? Nobody's ever put an emphasis on that in our practice. I will tell you that you will never be able to identify abnormal heart sounds if you don't listen to a lot of normal heart sounds. Okay? All right. So, if we have a S3, lub, dub, lub, dub, what do you suppose that is? Which one? And what does it mean? Mitral valve. And it's not slamming shut because there's too much pressure against it. And that's a good indication of congestive heart failure. When your mitral valve is not slamming back shut, it's because fluid's backing up, there's too much pressure against it, it's not being able to shut all the way, and that's what gives us this extra heart sound. Okay? So I've got a little video on heart sound and where to listen for them.
sensation that I was going to have.
When a healthy heart beats, it makes a lub-dub sound. The first heart sound, lub, also known as S1, is caused by the closing of the AV valves after the atria pump blood into the ventricles. The second heart sound, dub, or S2, originates from the closing of the aortic and pulmonary valves right after the ventricles have ejected the blood. The time interval between S1 and S2 is when the ventricles contract, called systole. The interval between S2 and the next S1 is when the ventricles relax and are filled with blood, called diastole. Diastole is longer than systole, hence the lub-dub, lub-dub, lub-dub. Heart sounds are auscultated at 4 different sites on the chest wall, which correspond to the location of blood flow as it passes through the aortic, pulmonic, tricuspid, and mitral valves, respectively. This is how similar defects associated with different valves are differentiated. Heart murmurs are whooshing sounds produced by turbulent flow of blood. Murmurs are diagnosed based on the time they occur in the cardiac cycle, their changes in intensity over time, and the auscultation site where they are best heard. Examples of conditions associated with common systolic murmurs include mitral valve regurgitation, when the mitral valve does not close properly and blood surges back to the left atrium during systole. The murmur starts at S1 when the AV valves close and maintains the same intensity for the entire duration of systole. This hollow systolic murmur is best heard at the mitral region, the apex, with radiation to the left axilla. On the other side of the heart, a tricuspid valve regurgitation has similar timing and shape, but is loudest in the tricuspid area, and the sound radiates up along the left sternal border. Aortic valve stenosis. When the aortic valve does not open properly and blood is forced through a narrow opening, the blood flow starts small, rises to a maximum in mid-systole at the peak of ventricular contraction, then attenuates toward the end of systole. This results in a crescendo-decrescendo, or a diamond-shaped murmur, which starts a short moment after S1. It is often preceded by an ejection click caused by the opening of the stenotic valve. Aortic stenosis murmur is loudest in the aortic area, and the sound radiates to the carotid arteries in the neck following the direction of blood flow. Again, on the other side of the heart, a pulmonic stenosis has the same characteristics, but is best heard in the pulmonic area and does not radiate to the neck. Other conditions that cause audible systolic murmurs include ventricular septal defect and mitral valve prolapse. An example of diastolic murmurs is aortic valve regurgitation. This is when the aortic valve does not close properly, resulting in blood flowing back to the left ventricle during diastole, the filling phase. As the blood flows in the reverse direction, the murmur is best heard not in the aortic area, but rather along the left sternal border. It peaks at the beginning of diastole when the pressure difference is highest, then rapidly decreases as the equilibrium is reached. Other common diastolic murmurs are associated with pulmonic regurgitation, mitral stenosis, and tricuspid stenosis. Thank you for watching. Please feel free to suggest a topic you want us to cover by leaving a comment below.
So, I would encourage you to start listening to heart sounds on people, especially cardiac patients and respiratory patients, just so that you start getting an understanding of what's normal so you can pick up what's abnormal. Does that make sense?
Is it best to listen with the bell or the diaphragm?
The bell.
The higher, is there higher tones?
Lower tone.
Lower tones.
So that makes a good point. So on your stethoscope, you have the bell and you have the diaphragm. The diaphragm is designed to listen to higher pitch noises, such as lung sounds. And the bell, the smaller part, is more geared for lower sounds, so primarily like heart sounds. So, all right. So this is in your book. It just tells you where it is and what's causing it and where to hear it. Not going to go through that. We just kind of heard it on the videos. So, what is a cardiac cycle? What is a cardiac cycle? This is the interactive part of class. What's that? One complete phase of the heart, right? So 1P, QRS, T. That's one cycle of the heart, right? So it gets both systole and diastole. This is where your left atrium fills with blood during diastole so that it can pump to the left ventricle, correct? Okay, remember that 70% of blood flow is due to pressure gradients. Only 30% of blood flow is from atrial contraction, which is called atrial kick. Why is that important? Because in atrial fib, what are your atriums doing? Are they kicking anything out? No, they're not pumping anything to the bottom, right? But yeah, people are walking around just fine with good blood pressure and good mentation and perfusion, right? That's because 70% of your blood flow comes from pressure gradient differences that's created by the left ventricle and the size of your container versus atrial kick, okay? So, we've kind of went through that. So, blood comes back to the right atrium, fills up the right atrium until the pressure in the right atrium is greater than pressure in the right ventricle. And then that valve opens, it equals it out till the pressure in the right ventricle is greater than the pressure in the pulmonary artery. That opens, lets it through. It does the same thing on both sides. So when two AV valves are open, the two pulmonic and aortic valve is closed. And all we're doing is changing compartments with pressure. Okay? So as long as your container's intact, your pump's working, and there's contents in it, we're good to go. Does that make sense to everybody? That's basically what all that says. All right. So remember that our heart's got 4 chambers, 2-sided. The right side is low pressure, and the left side is high pressure. So the right side has to pump against the pulmonary vasculature. So pulmonary vascular resistance. Okay? What could increase pulmonary vascular resistance? What? COPD, chronic lung disease. So think this through. When you have COPD, after 15 or 20 years of your chest never emptying and you're chronically hyperinflated, what's your chest do? You get a barrel chest, right? So that chronic inflation is putting pressure on the capillary beds. Because what's inflated? The alveoli. What surrounds the alveoli? Capillaries. So if I'm hyperinflated all the time, I'm putting pressure on the capillaries. That means the right ventricle has to pump harder and more pressure to circulate through the lungs. Right? So very similar to the left side that's pumped for years and years and years against hypertension, and then our muscle gets thick, right? Or it gets floppy. The same thing can happen on the right side from years and years and years of pumping against the increased pulmonary vascular resistance associated with chronic lung disease. Okay? And when we get into the 12-lead stuff, I'll show you some ways that you can look at that. All right. So what's the difference between veins and arteries? What? Okay, that's one difference. So typically arteries carry oxygenated blood and veins carry deoxygenated blood. Arteries carry blood to the body, veins carry blood back to the heart. What's the 2 exceptions? Pulmonary arteries and pulmonary veins. Okay? Our arteries high pressure or low pressure? High pressure. Veins? Low pressure. So what keeps veins from backflowing? Valves. Do we need valves in our arteries? No, because they're high pressure. One bigger difference is that arteries are made out of smooth muscle. So what can they do? Get big and small. Veins can't do that very much. They do a little bit, but not a whole lot. Right? So that's important stuff. So we have baroreceptors. What are baroreceptors? Pressure sensors. Where are they? They're in our aortic arch, our carotid arteries, right? And they sense what? Change in blood pressure, right? So I get let's say, a significant drop in blood pressure, senses that in my carotid arteries, my aortic arch, and then what happens?
Heart rate increases.
How? How does that happen? What? Your brain signals. So, here's how it works. The primary part of your central nervous system that can affect this is the autonomic nervous system. The autonomic nervous system has two branches, sympathetic, parasympathetic. Sympathetic's the fight or flight, right? That's your gas pedal, makes everything speed up. It's primarily driven off of adrenaline, epi and norepi, right? Your parasympathetic branch is your brakes, your breathe and feed, your rest and digest, slows everything down, and it primarily functions off of the 10th cranial nerve, which is starts with a V, ends with an vagus nerve. Okay? And if we stimulate the vagus nerve, what happens to our heart rate? It drops. Exactly. So, that's kind of how that whole system works. Now, what are chemoreceptors? Talk about baro being pressure. What are chemo? Chemicals. So what kind of chemicals are we recepting? How about oxygen and CO2 and pH? So what's our primary stimulus to breathe? CO2 levels, right? How does our body know that? Chemoreceptors. They're also located in your carotid arteries, your aortic arch, and your cerebral spinal fluid. So your cerebral spinal fluid senses a change in pH. It's typically caused by a change in CO2, because we know CO2 equals acid in the body, right? And so what happens? Our pH starts to drop because our CO2 goes up. Brain senses that through our chemoreceptors, sends a signal to our brain stem, our respiratory center, and what do? Faster and deeper, right? To blow off CO2 to do what to the pH? Balance it out, right? In a similar fashion, a drop in oxygen level causes the same response, but it's not as fast as the CO2 level is. Okay? So think back through how we get rid of CO2 or get rid of acid. Buffer system creates bicarb. Renal system is the last thing that happens. The respiratory system's in the middle. Right? Everybody remember that? All right. So, if I affect the autonomic nervous system and I affect the respiratory system, am I also going to affect the cardiac system?
Yes.
Why? But why in this case, either higher CO2 levels or lower oxygen levels, would I want to increase heart rate and increase contractility? To pump the CO2 out or to pump more oxygen in? Right? That makes sense? All right. Everybody knows we have large veins and large arteries. What's the primary ones we worry about? Carotid, brachial, femoral, aorta, superior inferior vena cava, right? Antecubital, popliteal, dorsalis pedis. That's the big ones. All right. So who knows what cardiac output is? What is it?
Ejection fraction multiplied by beats per minute.
Close.
It's the amount of blood pumped out by every minute.
Amount of blood pumped in a minute. Correct? How do we get there? We get there by heart rate times stroke volume. Okay? So cardiac output is the amount of blood that we move in 1 minute. Okay? As a general rule, it's somewhere between 4 and 6 liters a minute. Most people would say 5 liters in a female, 6 liters in a male. It kind of depends on your size. As a general rule, you have 80 mils of blood per kilogram of body weight. Does our left ventricle pump out every single milliliter of blood? No. That's called the ejection fraction. The percentage of that blood that's being ejected with each beat. Okay? Typically your ejection fraction is somewhere around 70 to 80%, which means 70 to 80% of the blood that's coming into the left ventricle is being ejected from the left ventricle. Okay, that's if our muscle's working like it's supposed to. Okay? Stroke volume is the amount of blood pumped by the ventricle with each beat. Typically somewhere around 80 to 100 milliliters. Okay, so think this through. Just simple. 100 milliliters per beat, 60 beats per minute. What is our cardiac output?
6 liters.
6 liters. Not that hard, right? What are some things that can affect cardiac output?
Higher and lower heart rate.
Heart rate, stroke volume. So, and that's primarily a function of not only how efficient your muscle's working, but also what's in there. If my ventricle is not full of stuff, it has nothing to pump out. Does that make sense? Okay? So is that going to decrease my cardiac output? Could the size of my container affect stroke volume and cardiac output? Absolutely. All right. So we just did this. Cardiac output is stroke volume times heart rate. Increasing stroke volume, increase heart rate, or increase of both to meet the metabolic demands of our body. What's the Frank-Starling law? Yeah, it's the rubber band theory. Theoretically, the more I stretch a muscle, the harder it will contract. The harder it contracts, the more it pumps, the more blood it pumps, correct? Okay? Where is this important? What patient is the Frank-Starling law really important in?
Right-sided MI.
Right-sided MIs, because they are preload dependent, and if we don't have enough preload from the right side to the left side, we have no cardiac output. So we have to use Frank-Starling's law to push more blood from the right to the left. How do we do that? Fluids, right? Simple. Increase preload, increase hydrant pressure. Stretches the right ventricle. We stretch the right ventricle, it pumps more to the left side. Left side has more to pump out to the body. It's simple hydraulics, right? And what did I say before? 70% of blood flow is what? From pressure gradients. Changing compartments with pressure. That's all we're doing. So what is contractility? Contractility. It's the efficiency of the heart muscle pumping. Okay? Without the extra stretch of Frank Starling. It's what it can normally do without stretching it. Right? So there's two different kinds of meds that can affect contractility. Inotropes and chronotropes. And from your pharmacology lecture, did she talk about positive and negative inotropes? Positive and negative chronotropes? Okay. So what's the difference between inotrope and chromotrope and dromotrope?
Chronos increase heart rate.
What?
Chronos
Yep.
increase heart rate.
Chronotrope increases or decreases heart rate. Inotropes increase or decrease the force of the contractions. So if I said that at 5 to 10 mics per kilo per minute, dopamine has both positive inotrope and positive chronotrope properties, what would you expect that to do to the heart? Increase heart rate and contractility. And if I do those two things, theoretically I should increase cardiac output. Right? Makes sense? All right. Next handout is this one right here. Okay, this is quite a bit deeper than what you learned in paramedic school. All right. So, what is inherent rate? If I say the SA node has an inherent rate of 60 to 100, so what does inherent rate mean? Normal rate, okay? Here's the cool thing about the heart. The heart has a fail-safe system. So our primary pacemaker is the SA, and its normal inherent rate is 60 to 100 beats a minute, right? If it fails, then we have a secondary pacemaker site. It's known as the AV node, or the AV junction. What's its inherent rate? 40 to 60 beats a minute. If it fails, my ventricles or my bundles and my Purkinje fibers pick up. And what is its inherent rate? 20 to 40. So think this through. If I have a junctional rhythm, what is my ventricular rate going to be? Junctional rhythm, 40 to 60. If I have a ventricular rhythm, like a idioventricular rhythm, it's going to be between 20 and 40. Right? If I have a third degree heart block, what's my ventricular rate going to be? Slow. Right? Because I have a total disconnect from the top to the bottom. Okay? So, the electrical impulses start at the SA node. And we know that 60% of the blood flow to the SA node comes from the right coronary artery, right? Okay, so think this through. If I have a very, very proximal RCA blockage, like I do an inferior, I do an RVI, I know that blockage is really high in the RCA. If I deprive the SA node of 60% of its blood flow, what's it not going to do? It's not going to work right. So what am I gonna see? Bradycardias. Right? That makes sense? Okay. On the EKG, what is represented? What represents atrial depolarization? P waves. All right. So, what do you know about P waves? Here's where we go deeper. Okay? They're kind of like T waves. The first third of a P wave is the right atrium depolarizing. The first third of the P wave is the right atrium depolarizing. The top of the P wave is both atriums depolarizing. And then the right 1/3 of the P wave is the left atrium depolarizing.
You say that again.
Okay, so the first 1/3 of the P wave is the right atrium depolarizing. The 1/3 in the middle is both depolarizing. And the 1/3 on the right is the left atrium depolarizing. I'm just going to go out on a limb and bet that paramedic school didn't go that deep. Okay. What are the characteristics of a normal P wave? Upright, but it depends on what? What leads you're in, correct? So what leads are typically upright P waves? 1 and 2 are typically upright P waves. AVR is an inverted P wave. That's normal. Okay? What's the size? Okay, remember when you look at EKG paper, from left to right measures time, and up and down measures amplitude or voltage, correct? So, in your limb leads, typically a P wave is less than 2.5 millimeters, which is 2.5 little boxes, because each little box is a millimeter. In your precordial leads or your V leads, it's typically less than 1.5 millimeters.
Say that again.
Yeah.
So in your limb leads, they're typically 2.5 millimeters or smaller. And in your precordial leads, they are 1.5 millimeters or smaller. I'm going to add something else. And this will make sense when we start talking about axes in a little while. A P wave's normal axis is 0 to 75 degrees. Bless you.
P wave normal axis is less than.
Is 0 to 75 degrees. You're going to learn something today because there's a really cool little feature on your 12 week that you probably didn't know about. All right. While we're in here talking about P waves, let's talk about heart blocks. Okay? A first degree heart block is merely a slowing of the firing through the AV node. It does not cause symptoms 9 times out of 10. There's no treatment for it. Okay? that's defined by a PR interval of over 0.22 or 220 milliseconds. So over 5 little boxes. Okay? A second degree type 1, or a Winky block, or a variable block, is blocked in the AV node. So some beats are getting through and some beats are not getting through. But because of the nature of that block, they're typically stable. So a type 1, second degree type 1 block is typically stable. It could get unstable if you had like a significant amount of blocks that aren't getting through. But as a general rule, it's like every fourth or fifth or sixth beat, because it gets what? Longer, and then it drops. That drops that one beat. So it's typically, every 4, 5, or 6 beats that drops one. So hemodynamically, usually the person can tolerate that without a problem. A second degree and a third degree, or second degree type 2 and a third degree block are both blocks in the bundle of His or distal from that. A second degree type 2 and a third degree heart block are blocked at the bundle of His or distal. All right. So typically what causes heart blocks? Half of them are caused by fibrosis, or basically tissue degeneration due to age. Okay, so half of them are caused by fibrosis. 35% of them are caused by ischemic heart disease. So either ischemia or an injury or an infarct. There's some other things that can cause it. So overvagal stimulation increases the release of acetylcholine, specifically on the AV cells, that can cause a block. Okay? What else could cause it? Structural defects, right? Like congenital heart defects can cause it. So things that are wrong with your heart structurally from birth can cause it. And then can some drugs cause it? Beta blockers, calcium channel blockers, digitalis, amiodarone. All of those kind of drugs can also cause heart blocks. All right. You have another sheet that has a bunch of P waves on it. Okay. So thinking through what I just said, when you look at a P wave in lead 2 versus V1. So our normal P wave in lead 2 is a nice round upright P wave, right? Our atrial depolarization is blurred in the middle, and so that's why it's nice and round. Okay? But look at the P wave in V1. What's normal? It's seeing that the electrical depolarization of the right atrium is positive, and the electrical depolarization of the left atrium is negative. So we get a dip. Different, huh? Okay? right atrial enlargement. What does that P wave look like to you? It's pointed, correct? And the right atrium is where the problem is, correct? Because look at the shape of that first third of the P wave. Right? So what could cause right atrial enlargement? Too much pressure in the right ventricle caused by too much pressure in the lung. So we see basically a pointed or a mountainous looking P wave. And you can see that in V1, it's very obvious that the right side is the problem because the left side looks normal, doesn't it? Okay? The next one is left atrial enlargement. So if you look at that P wave, our right looks okay, but what's wrong with the left? It doesn't go down like it's supposed to, correct? Okay? This is caused typically by a mitral valve problem. And how you remember it is that the P wave looks like an M. Looks like a mitral valve. Okay? And then look at the bottom one, which is both right and left atrial enlargement. All right, so back up to the right atrial enlargement. That big pointed P wave is called P mitral. A big P and then M-I-T-R-A-L-E. P mitral. No, that's wrong. That's P pulmonale. Right is P pulmonale because it's a pulmonary problem. And the M is P mitral. So the left, my bad, I'm confused. P mitral is left-sided because it looks like an M. P pulmonale is right-sided because it's coming from the pulmonary problem. Does that make sense? All you ever wanted to know about P wave. 10 minutes. You never knew all that stuff, did you?
Lee,
Yep.
so on the right atrial enlargement, the left side, how it slurs like that, is that just the left atrium going back like its normal pump? I
Yes.
guess?
Yep.
We see any of these in the right side or left side, does it change anything in our heads that we're doing?
Maybe. So if I saw P mitral,
Okay.
I might think of the possibility of congestive heart failure. And so I might be more focused in on making sure they're not in pulmonary edema. And then knowing that if they have P pulmonale, that there may be a significant respiratory issue there. And also, if you do have P pulmonale, then you might have to put more preload in because it's pumping against high pressure in the lungs. Does that make sense? Not, you're not going to radically change what you do. It's just something to help you make better clinical decisions. All right, so what happens? The SA fires, it goes through the bundle of Kent, gets to the AV node, it slows down. AV node kicks it through to the bundle of His, to the right and left bundle branches, the Purkinje fibers, and as electricity goes down through there, it causes each cardiac cell to discharge its energy. They do it collectively, which causes the muscle to contract, The muscle contracts, it pumps blood. Yep.
In the left atrial enlargement in V1, how would we, I suppose it just be enlarged, but like how much more, what would
Remember,
the amplitude?
1.5 millimeters, so a little box and a half. If it's over a little box and a half and pointed, then that would be something to. No. All right. When our cardiac cells discharge, we get a rush of sodium inside and a rush of potassium outside, right? Because our primary intracellular cation is potassium. Our primary extracellular cation is sodium. And there has to be an equal balance. And so that potassium in there, you get your resting membrane potential, which means it's all charged up and ready to do work. All it needs is a stimulus to go by it to make it discharge. That makes sense? And then what? We want to try to equal out sodium and potassium, right? That's what our body does, that sodium potassium pump. And then when we re-energize or repolarize, it goes the other way. Potassium runs back in, sodium runs out, equals out like it's supposed to be, right? We also have to have cation calcium 2 pluses because that's the primary cation that makes your muscle work. Okay, you have to have an adequate amount of calcium for your muscle to be able to contract. Okay? Think this through. What is this? Sodium. What's potassium? K with 1 plus. So if I have somebody that's got hyperkalemia, potassium's too high, what do I give for it? Why?
Just helps push the potassium back into the cell.
How? K 1 plus, Ca 2 plus. Calcium is stronger than potassium. That's why it pushes it back in.
That's for hyperkalemia, you said?
Yep, hyperkalemia. All right, why don't we take a break?
Everybody's through 5 miles.
This is a and all that pop.
That's it. Just out on a wheelchair man right now. So I do stay standby. It's 40 minutes. I go out to Newton and do go karting out there. And the guy had it just sitting there. I said, "What do you want for that?"